Hello everyone. In this video we're going to be talking about the pathology of asthma. So let's start. So what is this condition? So it is a chronic disease which causes the airways of the lungs to swell up and become narrow. This swelling and obstruction can lead to a lot of symptoms such as wheezing, shortness of breath, also called as dyspnea, a feeling of chest tightness, and cough. We will talk about this in more detail in just a bit. So now there are four types of asthma that you should remember. We have atopic asthma, non-atopic asthma, drug-induced asthma, and finally occupational asthma. Now let's see each of these in detail. Starting with the atopic asthma. So this type is mediated by IgE antibodies, which is why it's a type 1 hypersensitivity reaction. This type of asthma usually begins in childhood and it is triggered by allergens such as dust, pollen, or insects and their excrement such as that of cockroaches. There is usually a positive family history in this condition. So a positive family history and early onset of the disease can help you differentiate it from the others. Apart from this, if you do a skin allergy test, there will be an immediate redness and swelling in the area. Now, talking about the second type, which is non-atopic asthma. So this type is usually not due to any allergen, and so it is not a hypersensitivity reaction. It can be caused due to a viral infection, cold temperatures, and even because of something as innocent as exercise. Now, talking about the drug-induced asthma, this one's pretty interesting. So here there is sensitivity to drugs, usually aspirin, and there is a triad scene that you have to remember, which is called the Samter's triad. This triad consists of intolerance to aspirin, asthma, and nasal polyps. Now exactly how can aspirin induce asthma? Let's see. So all of you must be knowing that we have arachidonic acid, which has two pathways of metabolism. It can form leukotrienes using lipooxygenase, or it can form prostaglandins using cyclooxygenase. Now some of the leukotrienes that are worth remembering are B4, C4, D4 and E4. These leukotrienes have the capability of producing an asthma attack. Now where does aspirin come in all of this? So aspirin comes and inhibits the COX enzyme. So arachidonic acid will not take the prostaglandin pathway and will be shifted towards the leukotriene pathway more. Due to this, a lot of leukotrienes will be formed and this can produce an aspirin-induced asthma attack. Not only this, there is one important prostaglandin by the name of prostaglandin E2. Normally, this prostaglandin E2 inhibits the leukotrienes, like leukotriene B4. But now that we've given aspirin, the prostaglandin E2 will not be formed. And so, the inhibitory effect of the prostaglandin E2 on leukotrienes will be lost. So again, the leukotrienes will increase a lot and can lead to the attack. Now finally, coming to the last type of asthma, which is occupational asthma. This can be caused due to fumes, organic and chemical dusts, gases such as toluene, and chemicals such as formaldehyde. But to be honest, the previous three are more important to remember. Now, what is the pathogenesis of this disease exactly? Let's dive into it. So, there is an exaggerated Th2 response to the antigens. And as we just saw, the allergens can range from cold to even cigarette smoke. This will lead to release of interleukin 4 and interleukin 5. Interleukin 4 will increase IgE. Now IgE will go and attach to the mast cells, which will cause their degranulation. Now some of the substances that are released are histamine, leukotrienes and prostaglandins. Interleukin 5 on the other hand will activate eosinophils, which will release more cytokines and leukotrienes. Now these leukotrienes, prostaglandins and histamine which is released are the main culprit here. They will lead to bronchoconstriction, increased mucus secretion, or in short will lead to narrowing of the lumen. And this is what causes all the symptoms. Now what are the clinical features that you're going to see? So there will be a feeling of chest tightness as we discussed in the start. There will be dyspnea, there will be wheezing which will be heard on auscultation, and obviously coughing. So now let's hear what wheezing actually sounds like on a patient. I recommend using earphones or headphones for this part. Okay, finally, how can we make a diagnosis? So if we will do a spirometry test, the FEV1 to FVC ratio will be reduced. Normally it is more than 0.8, but in this condition it will be less. Why is that? Because this is an obstructive lung disease and this ratio is reduced in all obstructive lung diseases. So FEV1, if you don't know, is forced expiratory volume, which is the volume that is expelled forcefully in the first second. So meaning a person inhales fully and then starts to forcefully exhale. The amount of air that is expired in the first second is called the forced expiratory volume or FEV1. In this case, the FEV1 is decreased because the airways are narrow, meaning there is an obstruction to expiration. So the person will not be able to expire as quickly as a normal person because the airways are narrow, right? So that's why the FEV1 decreases and ultimately the FEV1 to FVC ratio also decreases. Now there are three C's of asthma that you have to remember. These three are found in the sputum of the patient. So what are they? These are Krushman spirals, Charcot-Leyden crystals, and Crayola bodies. These are important pathological findings that they can ask. Finally, this condition can lead to airway remodeling, and there are certain features of this that you have to remember. You will see thickening of the airway walls, there will be subbasement membrane fibrosis, there will be increased submucosal glands and goblet cells, and there will also be hypertrophy of bronchial wall muscles. They have previously asked questions on this topic. The question was all of the following are a part of airway remodeling in asthma except, and then you had to choose the incorrect one. So important to remember. Now, how are you going to treat this condition? So we can use bronchodilators such as terbutaline or salbutamol. We can use steroids and we can even use leukotriene antagonists. So that's it for this video. If you have any doubts, so please leave them in the comments or you can message me on Instagram anytime. The link for my Instagram is in the description. Thank you.